And it is now my pleasure to introduce our first speaker, Dr. Rasika Karnik from the University of Chicago, who has taken some time from her very busy schedule and very busy clinic to talk to us about what long haul COVID looks like in the clinic and what clinicians are grappling with and thinking about. So Rasika, I'm going to turn it over to you and you can go ahead and share your screen and get started. Thank you.
Wonderful. Thank you so much, Jim, for the opportunity to talk with all of you. And I really hope that I'm able to answer some of the questions that have popped up in the chat. So let me go ahead and share my, oops, one second. Let me share my screen and then start this. All right, can you see my slides?
We can see them, they look great, thank you.
All right. All right, can you still see my screen? I just want to make sure. Here.
Nope, we seem to have lost them. You want to try resharing?
Yes, give me a second here. How about now?
I am not seeing them. There we go.
Them. All right, so yes. Sorry about that.
No worries, thank you.
So again, here as Jim mentioned, I kind of want to give you a perspective of what I'm seeing as a clinician, and I'm trying to help everyone understand the needs of people living with post-COVID-19 syndrome. So a couple housekeeping slides here. There's a disclaimer that this program is supported by the Health Resources and Services Administration of the U.S. Department of Health and Human Services as part of an award totaling a little under $4 million with 0% financed with non-governmental sources. Contents are those of the authors and do not necessarily represent the official views nor an endorsement by HRSA, HHS, or the U.S. government. And I also wanted to thank Dr. Renslow Scherer, who's an infectious disease specialist at our institute, for sharing some of these slides. I have no financial disclosures, and here are the learning objectives. So to define post-acute sequelae of SARS coronavirus, describe clinical characteristics of post-acute sequelae, provide a framework for treatment and support of patients, describe ongoing research endeavors for people living with post-COVID-19 syndrome, and describe my clinical experience. So on to the first one. So in order to define a new disease process, first, we all need to agree on a name. So as you see here, I've kind of listed down, we've got long COVID, long hauler, chronic COVID, and which all mean the same thing. And then also a new term that the NIH has coined, so the National Institute of Health, is called post-acute sequelae of COVID-19, also known as PASC. So PASC essentially, in the most broadest sense, represents a failure to return to a baseline state of health after an acute COVID-19 infection. So on the right, you'll see attempts that the CDC, so and the NIH have made to describe long COVID. And I'll read those out to you. So preliminary reports indicate some patients may develop a so-called post-acute COVID-19 syndrome, in which they experience persistent symptoms after recovering from their initial illness. The syndrome appears to affect those with mild as well as moderate to severe disease. The incidence, natural history, and etiology of these symptoms is currently unknown. Often referred to as long COVID, these symptoms, which can include fatigue, shortness of breath, brain fog, sleep disorders, fevers, gastrointestinal symptoms, anxiety, and depression, can persist for months and can range from mild to incapacitating. In some cases, new symptoms arise well after the time of infection or evolve over time. And on the left, I wanted to highlight that you are seeing, news reports on post-COVID in multiple news outlets. And I think that the mainstream media has done really a service by bringing attention to this disease process. So there are varying definitions of when PASC starts. And depending on which organization that you ask, the answer varies. And I think this signifies the fractured nature right now of how we are studying this disease process. So the Open Forum of Infectious Disease basically has stated that they think that it starts 3 weeks post-acute infection. The CDC thinks that it's probably 4 weeks. And guidelines from the United Kingdom have broken it down in a different manner where they say, okay, acute COVID is up to 4 weeks. Ongoing symptomatic COVID is anywhere between 4 and 12 weeks. But post-COVID syndrome is when you have signs and symptoms that develop during or after an infection consistent with COVID-19 that continue for 12 or more weeks and are not explained by an alternative diagnosis. So how do you diagnose post-acute COVID syndrome? It's actually hard because we don't have a definition yet. However, some of the things that you would want to see before diagnosing somebody with this would be ongoing symptoms, which we'll get into later. And one of the following, a prior positive PCR test or antigen test, and the PCR being the deep nasal swab, a positive antibody test, or a good story. And that is generally for patients that, did not have access to testing or early on in the pandemic. Tell you, I was in Italy in February, and a week after coming home, I had these, horrendous fevers, cough, and whatnot. So we're not yet sure what the incidence of PASC may be. However, in published literature, the range is anywhere from 30 to 76% of people. It's seen in hospitalized, non-hospitalized patients, and most studies that have been published are relatively small single-center cohorts, so groups of patients. And in this table on the right-hand side, I I just listed, 3 different studies that you can find that are published, and in that's located, and you can read these, is China, then at the University of Washington, which is in Seattle. They essentially were able to follow 150 patients. I'm sorry, let me rewind here. So initially in China, they followed a little under 2,000 patients, and all of those were hospitalized. At the University of Washington, they followed a little under 200 patients, and out of those, 150 were all outpatients. Then in the United Kingdom, they have an interesting app where they track patients, kind of log their symptoms, and they can track how they're doing. And they looked at about 4,000 patients. And so you can see there's different incidences of long COVID depending on which study you're looking at. But the main symptom across the board is fatigue. In 2 out of the 3 studies, you have females that are suffering more so than males from persistent symptoms. And I like this slide because, it makes you kind of think about how we generally think that COVID is a lung disease, right? It affects the respiratory tract and people are having cough and shortness of breath and fevers initially. However, this slide kind of shows you that post-acute COVID, PASC, can really have any symptom in any organ system. And I will also mention that this picture is not inclusive of all the symptoms that can be seen. And here's another slide that I wanted to include in a figure that I thought was gives you another sense to sort of see that, like, you've got all of these symptoms on the left-hand side that people can have during the acute phase here. So you have all of these symptoms on the left, and they range from fatigue all the way to, to a runny nose and to lack of appetite. And then you have, people look to see like how many of these symptoms persisted in the post-COVID follow-up, and on average about 60 days. And you can see that none of the symptoms went away, right? Nothing disappeared. So, and this is as I said, about 2 months after the fact. And these were patients that were about 150 patients in Rome early on in the pandemic. So all of this to say, these last 3 slides, it's unclear who can get this, what symptoms they can have, and ultimately what will happen to them. And in order to help us better understand symptoms, we really need to understand the cause of this disease process, which we're not quite at yet. So there are multiple theories, and I just wanted to kind of chat through some of them. So some folks think it's just organ damage from the acute infection phase. Perhaps it's persistent inflammation. Your body is just continually reacting to something. Could it be autoimmunity? Or could you just have a low level of virus in your body that hasn't cleared yet? And possibly an inadequate antibody response. And there's a lot of talk about could there be some overlap with chronic fatigue syndrome, which is also known as myalgic encephalitis. And chronic fatigue syndrome is a lot of times thought to be caused by a preceding viral infection. So all of this to say is we're not quite sure yet. Moving on to the next point, and providing a framework for treatment and support for post-acute sequelae of COVID. So listen. A lot of people affected by PASC, from what I've been told, and now I'm also reading in the news, is that people are struggling to be heard and they don't feel validated by healthcare providers, their friends, and families. So I think it's really important to listen and validate symptoms. I also think it's important to encourage continuity of care and staying engaged with their healthcare providers, maintaining symptom diaries as well. And from a physician standpoint or healthcare provider standpoint, you really want to do some symptom-based diagnostics, so testing based on what the patient is complaining about, and evaluate their complaints and rule out other disease processes. So just because COVID is going on doesn't mean that people can't have other disease processes that are happening. And then a referral to appropriate specialists, including rehabilitation services too. That's been, from my standpoint, has been an important component of helping patients recover, is involving our rehab specialist. There also are counseling and peer support groups, and this could be at a local level, a national level, or even international. When I say local, you can look for community support groups, and different things will work for different patients. And national as well, through social media groups. Some folks find solace in those groups, and then even internationally. And I did want to actually bring up one group called Body Politic, and they have, it's a support group for patients that had COVID, and they have over 11,000 members. And they do actually focus on PASC patients. And then additionally, you can refer patients to post-COVID clinics. We have these clinics nationwide, and there is a website called Survivor Core, which I've included here, and they have a map of the United States, and based on the states that you're looking for, there are different clinics that are listed there and their contact information. And then also just to for all of us to be patient with the healthcare system and with science. I mean, this is a new disease process that's unfolding, and we're all learning. And we're all trying to do our best. So just encouraging folks that maybe if we don't have an answer today, we may have one tomorrow. And really, this is key, I think, too, is messaging to the general public to avoid infection. So get vaccinated when you can, follow CDC guidelines until that time. And that is to say that it's not, with COVID, it's not just about the acute infection that, okay, you may be hospitalized. It's also about this disease that we're now seeing unfold, where truly we don't have great therapy at this point. So we really want to try to prevent people from getting this in the first place. So now I'll kind of talk about some ongoing research. And so the National Institute of Health held a symposium over 2 days in December of 2020. And they identified key gaps in our understanding of PASC. And as you can see, it's quite an extensive list. And this is a table that they published a paper, and this table is included there. And I'll kind of read it off, but it's common terminology and case definitions at the first gap, which we chatted about earlier. We don't know what PASC actually is. So characterization of the epidemiology, including incidence and prevalence of various phenotypes, meaning could people present in different ways with PASC? Maybe some patients have just heart issues where their heart's racing, whereas other folks are plagued with diarrhea. So just trying to figure out what are these actual cluster of symptoms, and description of clinical spectrum and natural history of various phenotypes, identification of risk factors, including comorbid conditions, severity of initial disease, viral characteristics, host genetics, and host immune response. So very much basic science mechanisms of trying to explain what is happening. understanding of the pathophysiology, so the mechanism, and characterization of the influence of therapeutics for acute disease and vaccines in preventing or modulating post-acute COVID-19. So trying to figure out if somebody actually received remdesivir, does that influence whether or not they may actually have long COVID? And identification of therapeutic and preventative strategies for post-acute COVID-19. And I think that with PASC, I liken our current state of knowledge to where we were with acute COVID-19 a year ago, though much harder given the variety of symptoms that can exist. And more about research is that the NIH announced funding for a nationwide recovery cohort February of this year. And they were able to do that because Congress provided about $1 billion in funding for over the span of 4 years in order to support research into the prolonged health consequences of SARS-CoV-2 infection. And so currently, people have applied for that. The cohort has not started its study yet, but it's imminent. There's also a national COVID cohort collaborative, and the short form is N3C, and it's an open science community platform. So it's web-based, and it receives de-identified national patient data from centers all over the country of patients that had COVID, and allows for large-scale analysis. So they actually have 1.5 million COVID cases in their database. So this allows for people to look for patterns, and now they have actually started looking at PASC. So it's exciting. And then there's also another group, it's called C4, and that's, a lot of C's here, but anyways, it's a collaborative cohort of cohorts for COVID-19 research. And this is interesting because this group of patients, there were 14 different studies across the United States, and it includes over 50,000 adults. But these are groups of patients that were studied even before COVID happened. And so now they're looking to be able to use this group of patients to find, to see if, there's a change from their baseline health, and, to see how COVID may affect this group of patients. And it's really cool because they have information on these patients from prior. So when COVID wasn't even a thing, so you can really see if there are any changes in their health. And I also wanted to mention this study here. It's called the Patient-Led Research Collaborative, and it's exactly that. It was developed by a group of citizen scientists who were diagnosed with COVID early in the pandemic. And they actually created the largest global study of this emerging syndrome. And so they were diagnosed with COVID early in the pandemic, and then they started having persistent symptoms. And so they decided to take charge, and they created this survey to allow for people to talk about their symptoms and to sort of see if they could help further research. And so the study actually has results from more than 3,700 self-described COVID long haulers in 56 countries. And their results basically, and so some of the details regarding the study is that, as I said, it included a little bit under 4,000 individuals, mostly Caucasian females living in the US from between the ages of 30 and 60. More than half never sought hospital care, meaning that they were treated as outpatients or never even needed treatment during their acute disease process. 8% were admitted to the hospital, but about 2,500 respondents reported symptoms lasting greater than 6 months, which is a huge number. And symptoms have led to reduced work hours, and 22% stopped working. So there is a lot of impact to people's quality of life and their ability to do their normal activities. I will say there's a study flaw with this, is that it's self-reported. So there's no confirmed diagnosis with these patients, and you're really unable to tease out other causes. So that is certainly one major limitation, but I do think it's incredible that they were able to get this going, and shows a lot of initiative. And I think it's important that we recognize that patients are advocates for this disease process. It's kind of the last thing that I wanted to talk about was just to describe to you my own clinical experience. So I've been seeing post-acute or PASC patients since November of 2020. And admittedly, the visits were overwhelming with many symptoms to address. And I had to learn how to prioritize symptoms based on the subjective severity for the patient, or if I heard any red flag signs. So if they're like, my chest really hurts, but they glossed over that and talked about, something else like belly pain more. I really wanted to hone in on, things that I was worried about too. And I'll say the most common symptoms that I've come across are breathlessness and decreased exercise tolerance, palpitations, meaning like their heart's racing too, brain fog, sleep disturbances. Everybody's plan, nobody has a specific plan. So I saw that one of the questions kind of in the chat earlier, somebody wanted to know, how do you treat these patients? And there is no cookie cutter answer, and every patient is different, and we have to treat them that way. And so we tailor the plans for their specific needs. We see what works, what doesn't work. My other kind of, observation is that it's challenging to keep up to date on updates via mainstream media and published research. And that I have found that patients help me sometimes. They'll bring up things and, I look it up and we kind of work through these things together. And for me as a clinician, I think it's important just to sort of set aside your ego and say, okay, I don't know, everything, and people are able to inform me and my patients can inform me too. And then also I have been able to have some very interesting opportunities by involving myself in this space. I can engage with other members of the University of Chicago, and we do case conferences, and we kind of share our experience, and we try to work together to create a resource for patients that have PASC. And then also just the medical community at large. I partner with some other academic centers that also have a post-COVID clinic, and we try to work through things together. And so it's even sort of like my support group and how we can improve what we're doing over here. And then of course this talk. So it's been an interesting experience for me to be watching a disease process unfold in front of me. So in summary, I want to say that COVID-19 can lead to prolonged illness and persistent symptoms, even in young patients with no underlying medical history that were never hospitalized. There is no universally accepted, agreed upon definition or criteria. Much is unknown about how COVID-19 affects people over time, but research is underway. More time and research is needed to understand the underlying causative mechanisms, clinical course, and treatment options. And that we really need to validate, support, and continually educate ourselves in order to help our patients. So with that, I wanted to say thank you and to answer any questions that you may have.
Thank you so much, Rasika. That was a really beautiful overview, and you did a beautiful job. So thank you so much. I think based on some of the questions that came in during the Zoom storm, I'm going to ask one of those, and then we're going to segue over to Pato, and then we'll have some time at the end for more conversation. But you mentioned, there's not a cookie cutter approach. We don't really have any set treatments yet for long haul COVID or PASC. But can you give a few examples of things you might offer to people in terms of rehabilitative therapies or other things to help with symptoms? People who have been suffering with these symptoms for a year have to just be at their wit's end at a certain point. So what are sort of some things that kind of can help people feel better, even as we're trying to learn more?
Yeah, so it's a great question. So one of the things, so for example, some folks have complained about really just decreased exercise tolerance. Like they can't do the normal activity that they used to do. So they feel winded. People who have run a half marathon before now feel winded going up, a couple stairs. So first things, that we do, we will get pulmonary function tests, kind of evaluate for any significant heart problem or lung problem. We may end up getting an echo. We may get a cardiac MRI for these patients. We may do a Holter monitor to make sure they haven't developed an abnormal heart rhythm. And then if all of that is negative, so we will refer to our physical medicine and rehab specialists. And something that they do is they'll do a graded exercise program. So they basically try to increase their exercise based on patients' symptoms. They'll use their heart rate too in order to guide their physical activity. And we'll kind of work together with them and with a physical therapist to increase their activity levels.
Thank you so much for that. That's great. And thanks for hanging around for the end, when hopefully we'll have a chance to have some more questions. I would now love to turn it over to Pato. Please introduce yourself and take it away.
Thanks, Jim. Let me see. Let's first start with the talk. Can you see that?
Yes.
Yeah.
Looks
So,
good. Thank you.
yeah, I'm Pato Hebert, and as Dr. Karnik said, there are many names, but I do self-identify as a long hauler. And you'll hear about my journey over the last 14, 15 months in a second. But I wanted to thank Jim and AIDS Foundation Chicago for the invitation, and ATC Midwest. Really grateful to be here with everyone. And I appreciate everyone's vital efforts on the call. I have a 2.5 decades working in HIV prevention, mostly with queer communities of color. So I feel very much at home on this call and that I'm with my people. It's wonderful to see so many POC, and I'm really very, very grateful for the work each of you do every single day. I know how tiring it is and how much more difficult it's become under the pandemic, and very honored to be with you all here today, as well as Dr. Karnik. The title of my presentation is Lingering, and I'll just share as well the same disclosure form. Excuse me. Same disclaimer, excuse me. I've already disclosed, and I have no financial conflicts of interest. There are two main learning objectives, and then I'll tell you a little bit about how and what I'll share today. The first is to describe symptoms of living with post-acute sequelae and SARS-CoV-2, and to review COVID patient recovery advocacy needs and priorities. And I think you'll see there's quite a lot of synergies between Dr. Karnik's presentation and mine. I'm going to give my presentation in the form of an illustrated creative reading, and that's because I'm a visual artist and a teacher. And I also have, as I said, a long history of working in community-based HIV prevention. And I bring these tools to my struggle and my work with COVID. I tested on March 24th, 2020. So it's been quite a while now, and I received my positive results on March 27th. I told my family and my closest friends that day, and then the next day I went public on social media, in part because of what we know from our work in HIV and AIDS, all the stigma and discrimination. So I thought I'd read to you from that post that I did on March 28th, 2020, and then two other pieces of writing that I've done. And as I read, I'll show you images that I've made with my mobile phone in a large urban park in the center of Los Angeles. I made these images while slowly walking and trying to rebuild my lungs and my spirit while recovering. And I call this work the Lingering series. So, social media post, March 28th, 2020. Yesterday, I received a call telling me that I tested positive for the COVID-19 virus. Ever the artist, here are photos of me in the mask they gave me on Tuesday as I pulled into the parking lot for my test before I knew the outcome. I'm sharing to help counter the stigma of this virus, to ground it and to make it real, to remember that care can look and feel like so many different things, and that right now we must summon them all in our fragile, magnificent world. Isn't this quaint, seeing this old school LA County, printed out test diagnosis that actually came 3 weeks later? I got my immediate notification vis-a-vis a phone call. I say, I am diseased and well, fragile and strong, laughing and quiet, vulnerable and resilient, radiant and unsure, loving and loved. May you be loved and loving too. And so this is the mask that they'd given me upon entering for the test. And I, when I finished and was moving away, I put it on the seat, and I began to think a lot, as many of you who are providers know, of these ways, the PPE in contact with our bodies, and the way the PPE becomes a kind of body itself. It holds the memory of our bodies, that contact with our bodies. And it got me thinking a lot about the impact of the virus on this body and our collective body, as well as the landscape. So I started writing on social media, and then a friend of mine who's also a longtime HIV activist and a media scholar, Alexandra Yuchas, reached out, and she too was living with COVID. At the time, we didn't know it was long COVID, and said it's really important that we write these histories and that we share our experience, because at the time, many people, there were few people who knew somebody who was COVID positive. Now, of course, many people know many people, unfortunately. But at the time, in spring 2020, there was still quite a lot of mystery and uncertainty about it for many people in this country, at least. And so we ended up writing in the spring and early summer, And this piece called You're Still Sick was published in Bomb in the summer. So now this is 4 or 5 months into being sick with COVID. And what was happening a lot in April and May is that loved ones and friends and people who with all great intention cared about us kept saying, wait a minute, I thought you got sick in March. You weren't even in the hospital. You're still sick? And they kept asking this repeatedly. Of course, we now know that what Alex and I were experiencing and what I'm still experiencing is long COVID. So again, this is from the summer. You're still sick. And the image you see on the left, I'm walking in the park, beautiful, big, urban, sprawling park. And in this bramble, this dried flower bramble, this mask had somehow made its way down the hill. And where you're seeing blue are really dried flower heads. But I couldn't help but see a field of coronaviruses and this mask amidst them. And so this image started to become a kind of portal for me towards the body of work I'll now share. Science is only beginning to learn about what we have been living, just how complex and uneven recovering with COVID-19 can be. Recovering, a process, ongoing, so different from that shifting beacon of being already recovered. With COVID, it seems that sometimes there is no easy past tense, only a long and frustrating lingering. This means living with the virus's episodic and unsettling resurgence. Trust and optimism easily erode here. Confusion reigns in this dispiriting place and time of coronavirus recovering. Health feels unfinished, uncertain, incomplete. This is a different kind of flattening. So much talk of spikes, surges, waves, plateaus, hotspots, curves. This is again last summer. Just as regions and cities are now in varying stages of opening up, only often to close back down, we, the infected, are in various states of recovering. The world is nowhere near fully reopened, and we are nowhere near fully recovered. Instead, we live in a messy and ambiguous unfolding. When you're afflicted with COVID-19, all of your corporeal compasses can skew. This becomes particularly disorienting when you suffer through clear symptoms that eventually recede, only to reemerge. We have found that learning from each other and listening to each other are forms of confirmation more validating than any test. COVID-19 sufferers find buddies to authenticate our lived experiences and what is patently true in our bodies. Daily, seemingly unceasing stresses and previously unfelt assaults. And as the doctor reminded us, and as we know from our HIV work, of course, support groups become crucial for this. And I too am a member of Body Politic, which she mentioned. Way back in early March, again, this is 2020 I'm writing about, I had a sore throat, sneezing, a cough with phlegm, not dry. At the time, these were deemed signs that I was not infected with COVID. How little we knew, how much I would learn. Soon sleep unfriended me no matter how much NyQuil or melatonin I offered in seduction and supplication. By April, I stopped taking sleep aids because they made one part of me stumble toward collapse while my lungs clenched toward constriction. Late at night, I'd be yanked between these extremes, needing desperately to sleep, but unable to because my body anxiously wanted to breathe freely. In the bed, I developed elaborate positions on my side, with my head elevated on multiple pillows, spine extended straight toward my feet, a cushion between knees, free arm propped on hip away from weighing on lungs, torso torqued to the ceiling, all in hopes of inviting an open passage of air. I was exhausted during the day, and I dreaded the night. In spring, my emotional watershed was also reconfigured. I cried more than ever, weeps into sobs, into hiccups, into hopelessness. Patience, compassion, empathy, and generosity feel harder to come by now, for self, toward others. I'm regularly frustrated, yet too tired to be enraged. Doubt is pervasive, trust beleaguered. Even my biological belly is a cauldron. I've had ongoing and uncomfortable gastrointestinal issues, incessant bloating and gas, a few moments of diarrhea, daily bouts of inflammation, especially after any bits of sugar or gluten. On various nights, dispersed across several weeks, my gut wrenched with the telltale sign of food poisoning, but it was COVID. And this here is a coyote that had just crossed the road near desk on one of my walks in the park. There have been neurological logjams as well. Focus, motivation, and cognizance have all been adversely affected. Short-term memory can be a struggle. Trying to summarize what happened last week or even last night. Thoughts slide off the road and into the COVID fog. Word recall gets jumbled too. I can see a few letters, hear some sounds, but cannot find the word. Once, in mid-June, I tried to order mapo tofu for my partner. It came out Maputo, the capital of Mozambique, where I was scheduled to contribute to a global HIV prevention summit late last March. That historic gathering of activists was canceled due to COVID. Sometimes it feels like my mental dexterity has been too. This unevenness is distressing. Old symptoms come back to say hi again. The chest compressed as cortisol courses after a nightmare about street fighting with metal poles during the uprising. These symptomatic spasms add to COVID-19's emotional and psychic stress, its emergent and persistent scars. So then the third piece, final piece of writing I'll share is from my 1-year anniversary of first symptoms. So I wrote this on March 2nd, 2021, a couple of months ago. Posted about it. You can see Body Politic, the collective support group, and this was a fundraiser t-shirt for the collective that I was wearing that day. And I wrote back in early March this year, I am still here, with small announcements not quite my own. Seems strange to mark a year-long relationship with the coronavirus, to make ongoing room for its impact on my body and being. But the Rona and I are hardly alone. Lots of us long haulers are coming up on our 1-year anniversaries of being sick, and scores of the infected aren't even here at all. In the US alone, more than 500,000 people did not make it. Less euphemistically, they're dead. There's barely a day that someone I care about isn't telling me of a person in their life who has died from COVID. It did not have to be this way, does not. I can make my offerings of thanks for being here, and I do, daily, at least as often as I cry, which I do all the time now thanks to COVID-19 leaving me with a condition called Pseudobulber Effect. My neurologist explained the condition to me, the diagnosis for all my puddles. She said some people laugh, like the Joker in the Batman movies, and others cry, like La Llorona, I think, like me. I suppose this COVID symptom is also a syndrome, but I think of the tears as libations, and for me, they come most often in moments of wonder, appreciation, and joy. I can marvel at being able to take a walk and spend time with raptors. I can weep endlessly at your abundant generosity and love that sustain me, the tenderness and care, the unearned privileges and of ongoing healthcare and flexible work from home, the mystery of a body that is slowly better, if stubbornly not well, a body that does not quit. Yes, I can and should celebrate survival, feel hopeful at the arrival of vaccines, fret over us desperately needing them more for more than just rich arms and nations, hashtag people's vaccine. But in my small and vital celebrations, I am also minding the mourning and the reckoning to come. Forgive me if this makes me less than merry. Like you, I'm tired and ready for a new world. But La Covia Loca ensures that there is no forgetting or repressing. There's no racing ahead, no skipping the line, and there's certainly no going back. There's only the slow and steady making of a more just now. I hope this is the now that endures, an equitable now in which everyone can thrive. I hope this is the glorious hard work that grows and flourishes in time. I hope this new now is one of playful discovery together as sure as COVID and I have had to learn how to share this body. One long year, COVID, we be in it for the long haul, por vida, which is to say for life. Jim, I want to pause given time. I can quickly go through in 3 minutes some advocacy points, but many of them were already mentioned by the doctor. Do you want to open for questions?
Sure. I do think the advocacy points are really important.
Okay, I can go
if you wouldn't
quickly.
mind just sort of, popping through them, and then because I think we want to probably talk a little bit more about that. So a couple
Okay.
more minutes and we can open it up.
Okay, just want to be sensitive. So I think as we've
Thank you.
heard, lower thresholds, let's call it 10%, but the UW study, University of Washington study is saying 30% of those of us who get infected become COVID long haulers. And again, I was not hospitalized. I did have to go to urgent care for breathing, but I was never intubated or put in the ICU. Globally, as of last night, Google's telling us 159 million COVID cases. So if we try to wrap our hand around the scale of long COVID, that's 16 to 48 million of us already, with more every day. If we want to ground that in the context of Illinois, where you do your amazing and important work, 1.36 million cases, that's 130,000 up to 390,000 people living with long COVID. Massive, 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 massive scale to this challenge. We have to mind the needs of long haulers, even as we recognize the current strain on our systems, particularly in low and middle income communities. And I think as all of you do each day, and why I'm so grateful to be here, we need to deploy lessons from HIV, and I'm showing my global work here, but TB and malaria prevention, treatment, and care, but also from ME, what's commonly known as chronic fatigue syndrome, and building on the successes from folks who have worked against these illnesses for many, many decades while strengthening our systems. I mentioned earlier people's vaccine. We just heard the announcement of the TRIPS waiver recently. Need to really scale up production and distribution, as we can see from India and surrounding countries, but also in Brazil and elsewhere. Long haulers also need coordinated and comprehensive care, and it's part of why I'm so grateful to be in your company today. Ideally, we need case managers. Even with all of my skills and experience, I get completely overwhelmed having to move between specialists. I'm seeing 5 or 6 specialists, and none of it's coordinated by a central person except me. I can't even really manage the supplements and other things I'm taking. And of course, as we've already heard, we need more research so that we can better understand COVID in general and longer persistent COVID in particular. We have to rethink our expectations and our understandings of wellness, of work, and we really need to relook at how disability is understood and defined, which is something that the ME community has been advocating for many, many years. As we heard, many long haulers are unable to return to work on a full-time basis, some not at all. Huge, huge challenge. Those of you who've done work with folks in the lupus community or the MS community or the ME community may have heard of spoon theory. It was created by Christine Miserando. I'll just say briefly, it posits that we start the day with a certain amount of energy, and each activity we do expends energy, which those of us who are healthy may not even consider. But if getting out of bed requires 1 spoon and getting dressed another, taking some pills, a 3rd spoon, and you only have 12 spoons in the day, you can see how immediately depleted you get, right? And if going to the doctor takes another 4 spoons, you're already through half your energy for the day. So this has been very helpful as I've talked to other long haulers, but also advocates, providers, and just allies to think through what does that mean for the way we think about what a day looks like, what is productivity, what is well-being. Lastly, there's some hope. I mean, I think MERS and SARS, which is to say previous coronaviruses, suggest that for some of us, perhaps our COVID long haul conditions may improve over 1 to 3 years. That's not guaranteed, but there's some indication from previous responses. And lastly, because we don't yet know, we have to remain proactive now in concert with, of course, our vaccine and prevention efforts so that we're not having new infections and therefore new long haulers. I think that's it, Jim. We can open for questions. Thank you.
Thank you, Pato. That was really quite a stunning tour de force. And the two of you did a beautiful job today. And Pato, there's a number of folks in the chat who are also experiencing long haul COVID, and I think are really resonating with your comments today. So thank you so much for that. I think I have a question for both of you, and then there's a few questions that are coming up in the chat that I've captured. But a quick, it's not a quick or easy question, but if you can make it quick, there's almost 100, we have 100 people on this call and well over 120 who registered. What is one thing each of us could do, one concrete thing each of us could do in our lives, in our personal lives, our work lives, that could help improve what's happening in terms of the response to COVID PASC or long haul COVID? And I'll start with Rasika to give Pato a break, and then we'll go to Pato, and then I have a few more questions.
Pato, that was awesome. I just wanted to say that it was really nice to kind of see your visual depiction of what it's like as a patient, because I see patients just for a small period of time, it's not. So to hear about that was eye-opening for me. So thanks. Jim, to answer your question, that is a hard one. That is a really difficult one. So, what is something, I think I'm going to hone back into actually prevention. I'm a primary care doctor. I believe in prevention. And so if you can advocate for people to get vaccinated, if people are scared about it, or if they, have any sort of questions, like just push them to get answers and to ask people about it. But that's the one thing that I would say, because we don't have set treatment, we don't have, we don't even know what the pathogenesis is. So I would say prevention.
Thank you for that. And Pato, again, I know this is a question that's not quick or easy, but if there's one thing that we could all go and do when we go back to our lives today, and all the settings we're in, what would be something that would be helpful?
I'd echo the prevention continuum, right? From masks and distancing to certainly vaccination. And then I might say, I don't think anybody on this call would do it, but that we not gaslight, right? And the complexity, as Dr. Karnik said, and as I've shared, it's kind of overwhelming if you're a provider. Like, wait, where do I start? With the diarrhea or the breathlessness, right? And so to not gaslight, number one. And number two, if possible, particularly the folks in our personal lives, to follow up with those folks who we know might have gotten sick 6 months ago or 9 months ago or 3 months ago. And in the blur of so many infections, that we just follow up with each other to see, do people need a meal sent to them? Do they need a check-in? Do they need us actually to give them space and not text too much because they're overwhelmed and saturated with information? But to just mind that long COVID manifests over long, long periods of time. And even if someone's been well, they may have a relapse. So to check in on each other and keep doing that care.
Thank you for that. And I just wanted to comment, Pato, the numbers you gave us, when we're talking about potentially hundreds of thousands of people in Illinois alone with long haul COVID. And, we approximately have about 45,000 people living with HIV. So it really puts what we're doing with HIV in quite some perspective. And since we're at the beginning of this, we really have no idea where this is going or how long this is going to last, or if you all will ever find some relief from these devastating symptoms. So I really appreciate you also putting numbers to it. This is a quick question for Rasika. Is there evidence that vaccination impacts long COVID PASC symptoms? Does it improve it? What do we know about vaccination in terms of long haul COVID?
Yeah, I hate that. I think that my standard answer is we don't know yet for almost everything, but I will say that some patients get better with it. Now, I don't know. There are theories like, hey, maybe you didn't, the vaccine will help you produce more antibodies and kind of help clear the infection. It's one of the theories for long COVID. So people are looking at that. So I think actually there's someone in the audience, I think her name's Dr. Feldman. She sent me something that looks like somebody at Yale is actually trying to study, what happens for to folks that have COVID, have long COVID symptoms and get the vaccine, and then what their symptoms may be. So people are looking at it, but we don't know. And I will say too that because we wanted to encourage people to get vaccinated, we didn't want to wait to sort of study them and get blood samples and whatnot before saying, hey, go ahead and get the vaccine, to help prevent you from getting potentially COVID again. So it's the jury is still out there. Anecdotally, I will tell you some of my patients have gotten better. And then with the group of physicians that together that we are seeing patients, some of them have said anecdotally they've had a couple that have felt worse. So I don't know.
Thank you for that. And that's Sherry in the chat just said the same thing, like the vaccine made her feel worse, and Sherry's been dealing with long haul COVID. And then she also noted that some people get better. So That's what's also just really crazy about this, right? Is that it's just so different from person to person. I'm going to ask another question that came up in the chat, and then folks, if there's someone who wants to unmute their line and ask a question verbally, we'll take that in just a minute. But so get yourself ready if you want to do that. But this is a question that came in earlier from Sanford, Dr. Karnik, and wants to know if there's any research to your knowledge on variant acquisition and or reinfection with COVID amongst people with past COVID or long haul COVID.
So not with people that have PASC. I think that's just in general, like just a baseline studying that patient population is, that has not been very robust yet. But I will say, at least for patients that there was a Danish study with respect to just getting reinfected with variants. And they found that folks that were vaccinated had less of a chance of actually getting infected. And if you had COVID in the past, again, you have less of a chance of getting reinfected with the new variant. But folks that were older in age, they had a higher risk of getting reinfected. So, and when I say older age, I mean 65 and up.
Thank you for that. And now I promised we would hear from someone who wants to go on camera or go off mute, one or both, and ask a question or make a comment. So I'm going to allow the pause to linger. Anybody?
Jim, this is Paul Aarons. May I ask a question?
Absolutely, Paul. Thank you.
Yeah, I put a version of this in the chat before, but I'll revise it a little bit. I wanted to ask Dr. Karnik whether doing the pulmonary function tests and echocardiograms or mental status exams, does that correlate well with people's expressed symptoms? And do you follow those? Do they improve over time with the individual? And with the numbers that we heard, is that really a practical thing to use in terms of evaluating these folks with long COVID?
So let me, I guess that's like a two-part question. So the first part is, do all the diagnostic studies that we get, does that actually correlate to symptoms? No, not always. They do not. And we do find some pathology. So if there is a problem with their pulmonary function tests and it looks like maybe they have some sort of scarring in the lung, we will get a CT of their chest and we'll send them to a lung specialist. And I think it's a little too early to say what, like I've been seeing patients since November. Since November. And so it's about 6 months out. So it's not a huge span of time to, have gotten like repeat PFTs and whatnot. So, and I think this segues into your second question, which was, given the large number of patients, is it feasible to do all these studies all the time? And the answer is no, not without funding, right? Like, if people have copays, whether or not their insurance will actually cover it. So it's not feasible to do these studies over and over with people, which is why we really focus on what symptoms they have. And I also do want to address what you had mentioned about like a mental status exam. And I think maybe what you're sort of referring to, correct me if I'm wrong, is just sort of anxiety, depression, PTSD. And so we are looking at those scores. And with some patients certainly qualify as being depressed and being anxious. But whether or not it's tough for me to say what's the chicken or the egg. Is do they have a new anxiety disorder, or are they anxious because they don't know what's going on with their body? It's hard to say. But regardless, we treat the anxiety because whatever it is, whatever the cause is, if it's primary or secondary to the COVID, it's affecting their daily life. We treat it.
Oh, and also I was referring to the brain fog.
Yeah, the brain fog, that is a tricky one. That is a very difficult one because we don't know, like everybody has a different complaint and there's no set cognitive test where I can easily give a patient this test in like 15 minutes and say, okay, you have a problem with your, short-term recall or this functioning. So we don't have a quick test. And so what we've been doing at our institute is referring people for cognitive testing. And that's, it's almost a full day of testing for the folks. And so I actually don't know what the results are thus far. So our neuropsychologist has not come back to me with saying like, oh, I see this pattern in patients.
Thank you so much. I'm going to take ask one question that was still in the chat that I think people would be interested in, and then I'm going to ask each of you to give a final thought. Thanks for hanging out for a few extra minutes. I know we're past the half-hour point here, but Francis had asked earlier, and I think both of you could probably answer this from your own perspective, you both, Pato and Rasika. Are there any sources where folks can find research on how long COVID interacts with other conditions? So are there any good resources for information on this that people could check into online or otherwise?
Aside from the body politic, which I'm not a member of because I didn't have COVID, so that would be one place that I would probably refer people to try and find out. But nothing from like the medical community thus far, unfortunately. But that is a good point. And
Pato, do you have some suggestions?
Yeah, I don't know that we've got a great repository, right, that would hold both kind of the slowly emerging scientific literature, the slightly more accessible popular, right, so that we don't have to get all into the weeds, and then the anecdotal, right, from the patient side. But I would echo Rasika, and I'm part of 3 Facebook groups. There are many, and I'm part of Body Politic, and so when I have my GI issues or fog issues or how's the vaccine going to affect me, I'll often go in because there's a kind of crowdsourced wisdom. Obviously, you have to vet that, right? Every body responds differently, meaning every body responds uniquely. That's not the answer that I think we need and are looking for, which is we do need a kind of clearinghouse. And I do think that some of the patient-led research, I think, is a helpful kind of portal that can direct in some directions. And I think Body Politic are the 2 that I often refer people to, but that's not so helpful to providers. And I'm hoping that some of the larger meta research that Rasika is talking about will put us in a different place in 3 to 6 months so that we can have a centrally coordinated repository, which under the previous administration was just so under coordinated. Under the current one, which is still only 5 months in, I think there's a little bit better. Rasika, sorry, I think you were going to jump back in.
Yeah, I also wanted to say, reach out to like your local, academic medical centers or like large medical centers, because I think things are like constantly evolving too. So perhaps different groups sort of, pop up from time to time. So.
Thank you. And it just really just strikes me so much on how much this sounds like early days of HIV, where none of us really knew anything, and people living with HIV or getting diagnosed with HIV were doing a lot of crowdsourcing themselves without the internet at that time, and educating our doctors, and hopefully with the kind of attention and support that has been developed, and especially with this new administration, we won't be waiting for years to find some actionable things we can do. As we know, the HIV epidemic languished for quite some time because we had an administration who refused to speak about it, and thank goodness we don't have an administration like that right now. So with that said, I'm going to ask for final thoughts, quick thoughts to wrap things up from Pato and Rasika. Before I do that, just remind you that there's a evaluation link has been dropped in the chat one more time. So if you look in the chat now, it's there, just a few up. And please remember to fill that out. And we're going to go to Pato, and we'll close with Rasika. So Pato, your final thoughts.
I would just say thank you for being here, and 2 things: to please keep doing the work you do every day and taking care of yourselves. I mean, we've got many long haulers on the call, but even pre-pandemic, the work you do each day is vital and difficult and exhausting, even as it's inspiring and meaningful. So thank you for doing that work. HIV community needs us to stay engaged. That's the first thing. I think the second thing is to, no pun intended, but settle in for the long haul. I'm starting to use that as the metaphor, because it's going to take us several years, I think, to work through this long hauling, but also, as Rasika mentioned, the mental health piece. So many of us have been impacted, our loved ones have been impacted, particularly in communities of color, and that we do the care of self and others over these next 2 or 3 years, because it's not going to be a fast exit, even though things thankfully are changing quite quickly in some regards due to the vaccine. So carry on with our day-to-day, but also mind what's going to get us into this next 2 to 5 year window as we work our way through this. Thank you, Jim.
Thank you. Those are really wonderful and powerful words of wisdom. Appreciate those. And Rasika, you have the final thoughts for today.
I wish you had reversed it, because I think Pato really did a great job and very eloquent job of kind of what I would echo for final words. So I just want to say thank you to everybody, and thanks for the opportunity. Take care of yourselves, and don't forget the small things: eating well, getting sleep when you can, and exercising. So just take care of yourselves and your patients.
And I'll take the closing comments and thank both of our wonderful presenters. Again, you're getting a lot of love in the chat, both of you. Well deserved. Thank you to all of our folks who joined today, the more than 100 who logged in, and there's still 77 of you here, 10 minutes past the half hour. So it says there's a lot of interest here. We're going to continue to uplift this topic and try to help change the dynamic here. So stay tuned for further grant rounds. Again, we do COVID grant rounds on a variety of topics. So if there's something you're interested in us producing, please reach out. And Shanette has put the link once again in for the CEs. A reminder that we'll be sending you out the slides and a link to the recording. And with that, I am going to go off video and unmute. We're going to keep this open so you have a chance to grab the link there. But other than that, we're going to stop recording and say thank you for your time today, and look forward to some follow-up emails coming very soon. Take good care, everybody.